Hi, very good morning, all of you. So, this is our 29th live session, and this live session will focus on multiple choice questions discussion, right? Pertaining to Pedodontics. So, today and tomorrow, morning live sessions will focus on Pedodontics multiple choice questions. Hi, Tilali. Good morning. So we'll start our session with a beautiful quote. I'll just post it simultaneously here in the comments. Hi Ashina, Ramesh, Bernice, Megha. Hi, very good morning. Yeah, happiness is not something you postpone for the future. It is something you design for the present, as quoted by Jim Rohn. So happiness is not something you postpone for future. It is something you design for the present. So we'll go ahead with our multiple choice questions discussion. I'll just post the first question and options, and we'll give you some time, and then we'll start having discussion, right? Hi Nidhi, Pooja, good morning. Hi. So make sure that you have notes and notes along with you, so that you can note down important points pertaining to this session, right? So by the end of the session, I'm sure you'll be collecting a few valuable and important points relevant to periodontics. Yeah, here you go. So the first question, which of the following is most frequently utilized route of administration for sedation in pediatric patients? Is it oral route, inhalation route, IV, or IM? So which of the following is most frequently utilized route of administration for sedation in pediatric patients? Hi Abhishek, good morning. Good morning, Preeti. Yeah. So it is inhalation, as you all rightly said, and the commonly used agent is nitrous oxide, right? So conscious sedation and all, the commonly used route is through inhalation, and the agent which is being commonly used is nitrous oxide. So you can just make a note of these important points. So nitrous oxide, as you all know, it's also called as laughing gas because it has this all. I mean, it is having this poor analgesic property. However, it causes altered mental activity, right? So nitrous oxide, it is always coupled with no less than 20% oxygen, so it has to be combined with oxygen. So the minimum concentration of oxygen is 20%. Please make a note of it. So nitrous oxide must be coupled with no less than 20% oxygen, and it is quickly absorbed, and it is physically dissolved in blood. There is no biotransformation, and once the procedure, operative procedure is completed, then nitrous oxide, it is recommended that the patient be maintained on at least 100% oxygen for at least 3 to 5 minutes after the sedation period in order to reverse the concentration gradient of nitrous oxide. So nitrous oxide basically creates an altered state of awareness with impaired motor function. You can just make a note of this point. It causes altered state of awareness with impaired motor function. However, it produces a very little analgesia. The combined volume of gases being delivered, that is oxygen and nitrous oxide being delivered, should be at the rate of 3 to 5 liters per minute. So you can just make a note of these few important points which were discussed now. So the most frequently utilized route of administration for sedation in pediatric patients is inhalation, and the commonly used agent is nitrous oxide. And nitrous oxide should always be combined with oxygen at a minimum concentration of oxygen being 20%, right? And once the procedure is completed, right? So the nitrous oxide can be eliminated by displacing it with oxygen. So for that we need to use 100% oxygen for a duration of 3 to 5 minutes, right? So that's very important. And nitrous oxide, the basic mechanism of action, it creates this altered mental sensation or activity with impaired motor function. So there is altered state of awareness with impaired motor function and produces a very little analgesia. The combined volume of gases being delivered during the procedure should be minimum of 3 to 5 liters per minute, right? And the patient should be encouraged to breathe through nose with the mouth closed, right? So it's a pretty straightforward, direct question, right? Now we'll move on to the next question. Yeah. So it's regarding fluoridation. Let's see how you're going to answer it. So fluoride as such is very important topic in pediatric dentistry or in restorative dentistry for that matter. Hi Ashok, good morning. Good morning Kushbu. So the second question, we have around 2 statements, right? I'm just posting it now. Yeah, here you go. So we have 2 statements here. Good morning Fauzia. So the first statement says fluoridation has several mechanisms for caries inhibition. And second statement, included are enhancement of remineralization of enamel, inhibition, and it's inhibition of glycolysis. Sorry, I missed that point here. So second statement, included are enhancement of remineralization of enamel, inhibition of glycolysis, and incorporation of fluoride into enamel hydroxyapatite crystal. So it's not bihydroxy, it's a spelling mistake, right? It's a hydroxyapatite crystal. Hi Shivani, good morning. So coming to the options now. The first statement is true, the second statement is false. The first statement is false, the second statement is true. Both statements are true, both statements are false. So fluoridation has several mechanisms for caries inhibition. That is first statement. And second statement, included are enhancement of remineralization of enamel, inhibition of glycolysis, and incorporation of fluoride into enamel hydroxyapatite crystals. So which statement is true? So the options, first statement is true, second is false, vice versa. Both statements are true and both are false. Yeah. Yeah, okay. Yes, both statements are true. If you observe the first statement, obviously the second statement supports the first statement in the process, right? Yeah, you're all right. So there are several mechanisms for fluoride anti-karyogenic property. The first thing is, as you all know, the hydroxyapatite crystal. It is being converted into fluorapatite crystals, and these fluorapatite crystals are considered to be more resistant to acid dissolution, right? So that's the first mechanism which we are all familiar with. And second, there are also certain studies which have shown that because of the formation of these fluorapatite crystals, the surface morphology of crowns, they're altered in the sense the pits and fissures are not so deep, they're shallow, right? So that's another phenomena being explained, and that can be related to the first mechanism itself. And the second mechanism is this fluoride has the property of inhibiting bacterial enzymes, especially glycolysis, thereby preventing the utilization of these carbohydrates, right? So, glucose and all. So, in that manner, it prevents it has this anti-karyogenic effect because it inhibits bacterial metabolism. So, as mentioned in one of the statements, it inhibits glycolysis. And third important statement is it shifts the acid base balance. We have this remineralization and demineralization going on. It shifts the reaction in favor of remineralization. So these are three probable mechanisms through which fluorides exert their anti-karyogenic action, right? So to briefly summarize, fluorides exert their anti-karyous effect by three different mechanisms, right? So the first statement is true, and the second statement, the presence of fluoride ion greatly enhances the precipitation of tooth structure, fluorapatite, from calcium and phosphate ions present in saliva. And remember, this insoluble precipitate of fluorapatite replaces the soluble salts containing manganese and carbonate, which were lost due to bacterial mediated demineralization. And this process results in enamel becoming more acid resistant. So this acid resistance is contributed to the fact that certain salts which are more soluble like magnesium and carbonate, they are being replaced by this insoluble, relatively insoluble fluorapatite crystals, right? That's the reason why we have this greater acid resistance by fluorapatite, right? And second, incipient non-cavitated carious lesions are remineralized by the same process, right? And third, fluoride has antimicrobial activity, and to be more specific, in the second statement, if you observe, it's mentioned that it inhibits glycolysis, right? So to be more specific, fluoride ion inhibits enzymatic production of glycosyl transferase. The enzyme which is being inhibited is glycosyl transferase, and this glycosyl transferase prevents glucose from forming extracellular polysaccharides, right? So this process results or leads to inhibition of bacterial adhesion and slows the ecological succession of bacteria. So these are the three key mechanisms through which fluorides act. And we have this community water fluoridation, right? So the optimum level of fluoride concentration in the community water fluoridation, it's in the range of 0.7 ppm to 1.2 ppm. So 0.7 ppm is added in areas where there is tropical climate or hot climatic conditions such as India, because there is a greater consumption of water comparatively, so we have lesser concentration of fluoride relatively. But in areas in cooler climates, the concentration is 1.2 ppm. It's because of the fact that water consumption is obviously less in those areas, and that's quite logical to understand, right? So the amount of fluoride in community water fluoridation, ideally optimal is 1 ppm. It can range from 0.7 ppm to 1.2 ppm depending upon the climatic conditions, right? And that's another important point which you can make a note of. Right? So both statements are true. Yeah. Now let's move on to the next question. Yeah, this is very important pertaining to eruption sequence, chronology, and the number of teeth that are present at a particular time period or at particular age of a patient, right? So let me just post the question first. So it's a bit lengthy question. And this question is purely memory based. It's purely memory based. So here you have the question, right? A 15-month-old child would normally have all of the following teeth erupted except. So what are all the teeth present 15-month-old child? Options: primary lateral incisors and canines, primary canines and first molars, primary canines and second molars, primary central and lateral incisors. So which among the following is not present at the age of 15 months? Good. So you're all right on target. Bingo. Good. Hi Sadhana, good morning. Yes, Ashina, Linson, Preetika, Pooja, Preeti, Athileli, Ashok, Nidhi, Kushbu, Mega, Bernice. Yeah, you're all right. Ashok, you're giving us a sequence. Thank you. So, just make a note of it. At the age of, at the age of 15, the teeth which are present, yes, Preeti. It's not always ABDC. It changes with the arch. For maxilla and for mandible, the sequence is slightly different. There is variation in C and D. I just made a note of it. For maxilla, it will be ABCDE. For mandible, it will be ABDCE. So please correct me if I'm wrong. Right. So at the age of 15, the teeth which are present, the number of teeth that are present are 12. And the teeth include mandibular and maxillary, central and lateral incisor. You mean to say for mandibular it is ABCD? Just one second. Just check out. Okay. Let me just cross check what I have written again. So as per the information I have for maxilla, it is the eruption sequence is A, B, C, D, E. For mandible, it is A, B, D, C, E. Anyway, so let me just cross check it once again. Yeah. So at the age of 15 months, there are a number of teeth that are present are 12. And these include mandibular and maxillary, central and lateral incisors, all the first molars and all the canines, right? So premolars are obviously absent in primary dentition, right? So we do not find this second molars, right? Yeah, thanks Mega. Anyways, I mean, I have those eruption sequences also. I mean, they're all present in your dental anatomy textbook. You can just have a look. Yeah. So at the age of 15, you have all the deciduous teeth except second molars. Just make a note of it, right? I'm sorry, I've just given you a bit wrong information. Canines are not usually present at 15, right? So as I said, at the age of 7, the number of teeth that are present are mandibular and maxillary central incisors, right? Please try to make a note of these points. Age of 7, number of teeth that are present, mandibular and maxillary central incisors. Age of 11, the number of teeth that are present are mandibular, central, maxillary central, and lateral incisors, right? Age of 15, the teeth that are present are mandibular, maxillary central, lateral incisors, and 4 first molars, right? So total 12 number of teeth at the age of 15. At the age of 19, so along with mandibular, maxillary central, lateral incisors, and first molars, we also have primary canines present, and that is all 4 canines. The age of 23, approximately all 20 teeth are present in oral cavity, right? So just make a note of it, and we have to memorize it, no other alternative. Yeah, the eruption sequence which we have discussed helps you to visualize like which tooth erupts first, if at all there is any question pertaining to it, right? So coming to the question again, at the age of 15, a 15-month-old child would normally have all of the following teeth erupted except. So option A, so we have lateral incisors and canines, so it can be ruled out. Option B, canines and first molars, yes, they are present. First molars are present but not canines, so even this can be ruled out. Option C, primary canine and second molars, yes, they are present only after 15 months, right? So approximately at 19 months. And option D, primary central and lateral, they're present way back in first 7 months itself, right? So option C is the appropriate answer, as you all rightly pointed out. Yeah. Now let's move on to the next question. So, see, I mean, most of the students, when they ask like how to remember these eruption sequences and all, it's all noting down, right? So, this, I mean, we have to go by the hard way here. I mean, if at all we find any mnemonics here, we can try to memorize that way. Or else we have to go through the hard way, in the sense we have to take the pain, note the stuff, and try to memorize them at least once a day or once in a while. Then there lies the key. After a few days, you'll just master all these eruption timings, sequence, etc., right? Now, coming to the next question. So this question mainly focuses on the differences between primary and permanent teeth. So let's see how well you're going to answer. All of the following statements are true except. So you need to find out the false statement. So I'll just drop each statement and do select the appropriate one. So you have the first option. Here you go with the second option. The third. Fourth. Fifth. And finally, sixth. So you have lot many options. around seven options, right? So I'll just read out the question once again. In the meantime, you can think over it and answer. All of the following statements are true except the primary teeth, the first option. The primary teeth are lighter in color than permanent teeth. For primary teeth, the interproximal contacts are broader and flatter than permanent teeth. The pulp cavities are proportionally smaller in primary teeth. In general, the crowns of primary teeth are more bulbous and constricted than their permanent counterparts. The pulp horns of primary teeth are closer to the surface of tooth. The crown surfaces of all primary teeth are much smoother than permanent teeth. And finally, primary teeth have thinner enamel. So which of the following statements is false? So I'll give you some time because we have a lot many options here. Okay. Right. So let me just start with the discussion, right? So coming to the first statement, so we need to find out the false one, right? So let's see. First statement, the primary teeth are lighter in color than permanent teeth. So I have a question for all of you. We'll discuss the question at the end of the session, right? So the question is, why do you call the primary teeth milk teeth? So why do you call them milk teeth? So what is the reason for calling primary teeth as milk teeth? Right? So we'll just have a discussion, a brief discussion pertaining to that at the end of the session, right? Now, so the first statement is true. The primary teeth are lighter in color than permanent teeth, right? That's the reason why we call them as milk teeth also. By the way, the color of tooth is a mere reflection of the color of dentin because enamel is translucent, right? Next, second statement. The primary teeth, the interproximal contacts are broader and flatter than permanent teeth. I mean, if you observe, they appear more bulbous as one of the statements says, and the contacts are comparatively broader in case of primary teeth. Just have an observation, just Google out certain images, you will have an idea. They are much more broader and flatter than permanent teeth. Third statement. The pulp cavities are proportionally smaller in primary teeth. So while exercising cavity preparation, so while doing cavity prep in primary teeth, we should exercise caution because the pulp chambers are comparatively broad and they are present more towards the occlusal, or they're much broader comparatively, they're larger, right? So there can be chances of exposure, hence the cavity preparation depths and dimensions have to be shallow comparatively than their permanent counterparts. So the pulp cavities are proportionally smaller in primary teeth is a wrong statement, right? So the pulp cavities are in fact larger. And next statement, fourth, in general, crowns of primary teeth are more bulbous and constricted than their permanent counterpart. If you observe all the molars, right? I mean, even the canines and all anteriors, it's not so visible, but posteriors, especially, they look more bulbous and they are more constricted and will have a prominent cervical ridge also. So even that statement is true. Next, the pulp horns of primary teeth are closer to the surface of tooth. Very true. And the crown surfaces of all primary teeth are much smoother than permanent. So it's a relative statement. So relatively we'll have a smoother surface, like less incidence of pits and grooves in primary. And obviously primary teeth has a thinner enamel. Right? So all of the statements are true except the third one, which says that the pulp cavities are proportionally smaller in primary teeth, right? So that's a false statement. Yeah. So you're not giving me a chance to discuss that at the end of the session anyways. Good. Glad that you all know the answer. The refractive index of deciduous teeth is similar to that of milk, which is approximately 1, around 1. I mean, it will be like 1, I think it's for water. I don't exactly remember, but we have that standardized value 1, but it will be in and around 1. So, the refractive index of milk tooth, is similar to that of enamel, hence, it's called as milk teeth, right? Good, Abhishek and Ashok. So, right, so Linson, hope it's clear. The answer is clear now, right? Bernice, hope it's clear. Yeah. So, rest of you have answered it right. Next, let's move on to the next question. Yeah, this is related to vital pulp therapy. I mean, in fact, it's not vital pulp therapy, but it comes under restorative treatment, right? So, the question is, so it's pertaining to indirect pulp capping, IPC, right? So you have the options here. So option A, option B, option C, and option D, right? So indirect pulp capping treatment is a procedure performed in a tooth with options: a necrotic pulp, a deep carious lesion adjacent to the pulp, a periapical radiolucency, and finally pulp tissue that is irreversibly infected due to caries or trauma. So we almost have an unanimous answer. Yeah. So I guess you need not need an explanation also. Anyways, I just have a question for you. What is the rate of reparative dentin formation? I mean, like how much amount of dentin is formed every day? We've already discussed this in one of the videos in YouTube also, where I have mentioned about IPC and DPC, indirect and direct pulp capping. I mentioned the same in that video. Anyways, what is the rate of formation of reparative dentin? So, as you all rightly said, yeah, 0.2 mm translates to, I mean, can you translate that into microns? No, it can't be 0.2 mm because 1000 microns is 1 mm. So, according to you, 100 microns, 0.1. So, 200 microns per day? No, yeah, no. Yeah, yes, Preeti, bingo. Anyways, Pooja, well tried. So it's not 0.2 mm. 0.2 mm is around 200 microns, right? Which is greater comparatively. I mean, in terms of tooth and dentin formation, it's 1.4 microns per day, right? Good. So a deep carious lesion adjacent to pulp, yes, Nidhi. A deep carious lesion adjacent to pulp, where we go for direct pulp capping, right? So if at all we feel like radiographically and clinically, if the excavation of that pulpal tissue can lead to exposure of pulp, then what we do is we retain only the affected dentin but not infected dentin, right? So again, we discussed the differences between infected and affected in one of the videos, right? You can check out the playlists and videos for more information. So infected dentin is removed, affected dentin is retained at the deepest layer, and then we will place a liner, preferably calcium hydroxide, with an intention to promote the formation of a dentinal bridge, right? Tertiary dentin, right? So a deep carious lesion adjacent to pulp. And what is the time periods, right? You place calcium hydroxide in deepest layer, go for permanent restoration, and you recall the patient at least after 6 to 8 weeks, or as per the statement reference here, will recall the patient. I mean, if you observe Marchuk, they have mentioned that after direct pulp capping, the recall period has to be around 6 to 8 weeks, and for indirect pulp capping, it has to be around 4 to 5 weeks, right? We should recall the patient again, check for the symptoms, check for the signs and symptoms, right? And based on that, we should proceed. If it is symptomatic, then we need to go for conventional root canal treatment. So we have a few important points related to this indirect pulp capping. Evaluation and restoration of tooth treated with indirect pulp therapy. So when do you consider indirect pulp capping as successful? So as I mentioned, when you recall the patient, there shouldn't be any signs or symptoms, right? So there shouldn't be any tenderness or percussion, there shouldn't be any incidents of pain, spontaneous pain, any hyperemia, symptoms of hyperemia of pulp, right? And also radiographically, there shouldn't be any changes in pedial space, periapical space, no radiolucencies, no internal resorptions, etc., right? And most importantly, as we discussed yesterday also, there has to be formation of reparative dentin. I mean, the calcified bridge formation can be evident on a radiograph, right? So absence of subjective complaints, that is toothache. After 6 to 12 months, a periapical and bite wing X-ray revealed deposition of new secondary dentin. And finally, without any radiographic changes, you can consider RPC as successful, right? Okay, here we complete our fifth question today. So, I mean, are you guys able to follow what I'm able to explain you? Uh, do you wish to continue, or shall we stop it here? Okay, is it fine? Like, are you able to follow? Or do you want me to increase the pace, or do you want me to continue at the same pace? Or do you want me to still slow down the pace at which I am explaining you? Okay, sure, and thanks for the feedback. Abhishek, you want me to go a little faster? Okay. Anyways, we'll go by the majority. Yes, Abhishek, we can cover maximum topic. Yeah, even I would love to do that, but at the same time, there shouldn't be any compromise in the quality. Quality in the sense, if I keep on running, I mean, I can go fast, but I'm not sure whether all of you will be able to follow it or not, right? It's not that you're not capable of, but it's about the gap which can be formed in the process, right? So I don't want that to happen. So I'm trying to go at a medium pace, right? Anyways, we'll go by the majority. Uh, yes, Ashina, Prati Abhishek, Mega, Bernice, Nidhi, Ashina. Okay, Ashok, Tileli, sure. Right, so we'll proceed with the next question. Yeah, here you go. Which treatment is the proper one for a class 2 fracture of a permanent tooth with immature apex? So class 2 in the sense L is class 2. Uh, I guess you're all aware of it, right? So dentin involvement. So we have options. Option A, pulpectomy. Option B, pulpotomy. We have pulpotomy also. And then we have another option, apply calcium hydroxide and restore the tooth with permanent restoration. And another option, just wait and observe. Yeah, here you go. Which treatment is the proper one for a class 2 fracture of a permanent tooth with an immature apex? So immature apex, young permanent tooth, you have blunderbuss canals. I'm sure you're all aware of it, right? So immature tooth is the one where the apex is wide open, and such scenarios we see in YPT, young permanent tooth. So young permanent tooth is the time period where the sooner the tooth erupts for another 1.5 to 3 years or 2 to 3 years, the apex remains open. I mean, for the apex to get closed, it takes around 1.5 to 3 years, right? So till that stage, the tooth is called as young permanent tooth, and the canals are wide, and these wide canals are called as blunderbuss canals, right? Blunderbuss. So few of you say apply calcium hydroxide to expose the dentin with permanent restoration, and few of you say observe. No, it is Ellis classification. Tileli, what is Vanek's classification? Can you please share? Always remember, whenever there is exposure of dentin in anterior teeth, especially during trauma, it's always advisable to place a liner, a calcium hydroxide liner, and then go for composite, right? So yesterday also we were coming across one case where there was Ellis class 2 fracture, and there is clear-cut dentin involvement. If you go for acid etching, already the patient complains of sensitivity, right? There was a history of trauma a few months ago. So already the patient has this sensitivity. So again, you go for acid etching. If you go for 5th generation bonding agent, right, you have this etching and rinsing concept, right, total etch. So when you go for etching and rinsing, there will be again increased post-op sensitivity, right? So it's always better if you go for a liner placement, and then once it sets, go for a traditional way of placing composite, or if possible, use a 6th generation or 7th generation bonding agents, that is self-etch adhesives. Yeah. So which treatment is proper one for class 2 fracture of permanent tooth with immature apex? So we have options: pulpectomy, apply calcium hydroxide to expose the dentin and restore tooth with a permanent restoration; pulpotomy, and then observe. So option B, apply calcium hydroxide to expose the dentin and restore tooth with a permanent restoration is the appropriate answer, right? So we'll just make a note of these additional points, right? Emergency treatment of fractures for permanent teeth with immature apex or open apex. So if it is a class 1 fracture, it's only enamel involvement, right? So what is the treatment? It is smoothen the edges which have been fractured or which have become irregular, right? Smoothen enamel edges and restore the tooth. Always remember, like few of you have answered metapex. Okay, Mega. I'll just come back to you, right? Okay. So, in case of class 1 fracture, remember, few of you answered option D, right? So just observe. See, we'll go for observation only when necessary. But here there is loss of tissue, right? Loss of tooth tissue. So you just can't observe. You have to go for a definitive mode of treatment, right? So you need to restore it. Now, in case of class 1 fracture, you smoothen the enamel edges and go for restoration, right? And in case of class 2 fracture, as we discussed now, place calcium hydroxide liner and go for restoration, permanent restoration. And option, if in case there is class 3 fracture, right? So class 3, there is obviously involvement of pulp, right? So you can go for, I mean, if the fracture, as we discussed yesterday, pinpoint exposure of pulp, you can go for direct pulp capping, or if there is cross exposure involving the pulp, then we go for pulpectomy, right? So pulpectomy followed by a permanent restoration, right? So conventional root canal treatment. So class 3 fracture, immediately after injury, apply calcium hydroxide over exposure, place a temporary restoration. If the exposure is large or the injury has several hours or days ago, perform calcium hydroxide pulpotomy. Once the apex closes, do pulpectomy. So since we are dealing with young permanent tooth, this is very important. So as one of you asked, as Megha rightly asked, so since it's an young permanent tooth, in case of class 3 fracture, depending upon the vitality, we go for either apexogenesis or apexification, because our aim here is to close the apex, right? So once the apex is closed, ultimately you go for conventional root canal treatment. But before that, you go for either apexogenesis or apexification based on the condition of a tooth, right? Based on whether it's vital or non-vital. So class 3 fracture, if it is pinpoint exposure, then we go for direct pulp capping. If the exposure is larger or it has occurred several hours before, then you can try calcium hydroxide pulpotomy also, right? Once apex closes, then you can go for complete pulpectomy. And class 4 fracture, right, non-vital tooth. So we can plan for calcium hydroxide pulpotomy. Once apex closes, again we can go for traditional pulpectomy and root canal procedures, right? So even in class 4, that is non-vital teeth, our aim is to obtain this apex closure, right? So ultimately, once apex closes, only then it's feasible for us to perform conventional root canal treatment with a fair degree of success, right? Because we need to have a positive stop while preparing the canal, during biomechanical preparation, and also during obturation. So just make a note of these points. Class 1, the line of treatment. In case of, we're talking this in terms, I mean, in cases of young permanent teeth. So class 1, class 2, 3 and 4, right? So now coming to your query, Megha. Metapex is, as we discussed yesterday, it's a combination of calcium hydroxide and iodoform. This is the one which we use during, we can use it during apexification, right? So we'll be applying Metapex. Of course we go for it. And moreover, this Metapex is mainly used as an obturating material, right? So as we discussed yesterday, this Metapex or KRA paste or zinc oxyreginol paste, they're mainly used for obturating material. Yeah, even during apexification procedures. So in this case, since the tooth is vital, right, so we can't go for Metapex placement. It's a paste consistency, and for any material to be used as a liner, it has to be hard setting, right? So you can't use Metapex for direct pulp capping. And Thileli, I haven't mentioned that after direct pulp capping, you go for root canal treatment. We're talking about apexogenesis and apexification. Only in cases of apexogenesis and apexification, once the root apex closure has been achieved, then we go for conventional root canal treatment, but not in case of direct pulp capping. If it is successful, then happy, right? We can maintain. Ultimately, we need a tooth which is vital, right? So that would be the ultimate aim. Even the goal of regenerative endodontics is the same, right? It's trying to obtain the lost vitality of a tooth. We can leave a tooth without RC after the successful DPC, right? Hope it's clear, Megha and Thileli. Right. Thileli, you say, in case of apexogenesis, the concept is different. I didn't get you. You're trying to club direct pulp capping and apexogenesis. Both are different, right? Anyways, if possible, try to reframe the question and post it again, right? Yeah. So we'll discuss the next question. Okay, we'll just conclude with this question, right? It's already 6. So You're all aware of this. Yeah. Anyways, we'll just try to briefly conclude with this question, right? So, direct pulp capping. DPC, right? Direct pulp capping involves direct placement of capping material on the pulp. Dash is the agent that is most frequently used. So you have the question now. Options include cavity varnish, glass ionomer, zinc oxide eugenol, and then you have calcium hydroxide. Yeah, I guess you need not see the options also, right? So apart from calcium hydroxide, now we have a question. So if at all we have other options. Okay, Abhishek, you have a broad smiley. Okay, fine. What about other materials that can be used for direct pulp capping? Any other materials that can be used for direct pulp capping? We already discussed this yesterday also in live session. Zinc oxide eugenol. Eugenol has this property of irritating the pulp. Anyways, okay, well tried, Bernice. I mean, you have any other better options? Like what other materials? Yeah, Sheena, good. So you say biodentine and MTA, right? Anything else? We discussed yesterday one particular point. Yeah, biodentine, MTA, formicrosol. No, formicrosol, gone. Your tooth is gone. We can't use formicrosol, Pooja. Formicrosol, as one of you asked yesterday, it's a fixative. It helps in mummifying, right? Fixing the tissue. There is, one agent which we discussed yesterday. I mentioned the name of the author also, FUK, Fuchs et al. I said that she has done some studies. She compared calcium hydroxide and also other material. So, okay, let me just give you a hint. It's a component of KRI paste. They're all in partial pulpectomies, right? We're talking about Pritika, Buckley's formula, KRI paste, Tinkock. They're all for. We have this partial pulpectomy. Buckley's formula is for pulpotomy, right? You're talking about direct pulp capping. Okay, let me just give you a hint. It is one of the components of composite. I'm sure you can answer it now. Bingo, Ramesh. Vitapex and all, they are used in root canals at obturating materials or medicaments. Vitapex is nothing but zinc oxide eugenol with iodoform, right? What is urethane? Bernice, can you please elaborate? Anyways, as Ramesh rightly said, it's an adhesive bonding agent. Even studies have shown that covering the exposed pulp, isolating it and then covering it with bonding agents, few studies have reported greater success, right? So even that could be a viable option. However, there are many studies contradicting this point also. But since it's mentioned in a standard textbook like McDonald's, you can just follow it, right? However, the gold standard material that is considered, the material considered as gold standard is calcium hydroxide. Right. So the question again, direct pulp capping involves direct placement of the capping material on pulp. So which material is most frequently used? The most frequently used material obviously is calcium hydroxide, right? Along with that, we can even go for placement of biodentine, MTA, recent modifications of MTA like MTA plus, and also you can go for dentin bonding agents. However, it's of historical importance, right? So the most appropriate answer is calcium hydroxide, biodentin, and MTA. And now to the question again. Direct pulp capping is not done in case of deciduous teeth, as we discussed yesterday. It's because of the greater irritation potential of calcium hydroxide, which has greater pH, where it increases the chances of internal resorption in the deciduous teeth, right? So hence we do not advocate direct pulp capping in case of deciduous teeth, right? You can just go through this live session where we have elaborately discussed this important point pertaining to direct pulp capping not being done or followed for primary teeth. And direct pulp capping, the size of exposure, they say pinpoint exposure, it's 0.5 mm or 1 mm, right? So we used to follow this 1 mm concept, but in Sturtevant it's mentioned as 0.5 mm. So depending upon the options, you answer it appropriately, right? Yeah, there are greater chances for internal resorption, Tilali, right? Yeah. I think you're getting, most of you, I feel like you're getting confused between different materials being used. You should have this clarity, right? So, in direct pulp capping, we use calcium hydroxide, right? Direct pulp capping, as I said, calcium hydroxide, MTA, biodentin, bonding agents, right, as per the literature. In case of partial pulpectomies or those materials that are placed inside the canal for sake of obturation as a medicament, etc., they include zinc oxide eugenol, a thick consistency, right? Zinc oxide eugenol cement or KRI paste, which is nothing but combination of zinc oxide and iodoform, or Metapex or Vitapex as mentioned, right? So calcium hydroxide and iodoform, they're used inside the canal, right? Yeah, that's very important. And pharmacrystal, it's for pulpotomy techniques. Just don't get confused. There can be, of course, overlapping once you're trying to get lot of information. Since I have done my post graduation and since we have seen these materials repeatedly, maybe I'm having this clarity. But even during preparation, we have this confusion, like which material for what. So just make a note of it. Just visualize, just watch the procedures if appropriate, right? So watching the procedures in fact helps you in learning it easily, right? Theory and all, only theory, it's literally really boring and you just can't get the things inside you. If possible, watch a clinical procedure of pulpotomy or partial pulpectomy or direct pulp capping or indirect pulp capping. We have plenty of videos in YouTube. So once you watch them, you will have utmost clarity without any confusion or ambiguity, right? So we're done with this question also, right? So we'll just conclude with this, and so hope you could follow and hope you got some important points, important relevant points pertaining to few important aspects, right? And it would be great if you make a note of these points, right? So all these points and all which we have been discussing extensively in each live session, they will be very much useful before revision, right? So that gives a lot of confidence, a lot of authentic information, which is very much essential for gaining confidence, right? So you have any further queries, you can always mail us at proudtobedentist@gmail.com. Thileli, you have a question? Okay. Yeah, yes, I agree with you completely. I got your point now. Yes, if it's an immature tooth, if apexogenesis is successful, and if the tooth is vital and healthy without any clinical changes, any symptoms, without any radiographic changes, then of course you can leave. Of course you can live without RCT. Yeah, agreed. If it is vital, then of course, when you compare vitality, vitality is the one which everyone desires, right? So that there can be appreciation of function also. Vitality, restoring the lost vitality is the key, and it's been the ultimate aim of regenerative endodontics as well. Yeah, only for apexification we can go for a root canal treatment. Okay, as I mentioned, right? So only for apexification we can go for root canal treatment, but for apexogenesis, if it is successful, yeah. Just wait and watch policy. Periodic observation of every 6 months, 12 months to check out the signs for any radiographic changes or etc. Right? So we'll try to evaluate the tooth periodically and monitor it, and based on that we'll proceed accordingly. If in case there are any symptoms, etc., then we proceed with root canal treatment or complete pulpectomy, right? Yeah. Right. So you have any further questions, you can post and I'll be happy to answer them. You can always mail us at proudtobedentist@gmail.com, right? So I'll just post our mail ID here. So keep the momentum going, give your best, and make sure that you stay focused, right? So have this, I mean, most of you, I'm glad that most of you are joining me live at 5 a.m. I mean, I'm not sure whether you have this routine of getting up at 5 a.m., but it's the best habit you can ever incorporate in your daily life, not just during preparation, but any time, any moment in life, right? So you'll have plenty of time, you can do things which you really love, and that gives a lot of energy and a sense of hope for future, right? So I advise all of you to watch the 5 a.m. club video. Even though the clarity is not so good, we have done one live session recently on 5 a.m. club. You can just watch it. The importance of getting up early in the morning, right? So you're all welcome, Bernice, Ashok, right? So keep smiling. Have a nice day, right? So for any further queries, you can contact us at proudtobedentist@gmail.com. Bye. Have a nice day. Keep smiling.